So thank you very much for the opportunity to speak with you today. I'm going to change gears just a little bit, and although I'm talking about molecular mechanisms of atherosclerosis, I really would like to concentrate on these three topics and actually take us back to an integrated whole body pharmacology. And the three topics that we'll talk about in the molecular mechanisms of atherosclerosis are that atherosclerosis, number one, is a continual response to injury of the blood vessel. That multiple genomic factors can influence the rate of progression by causing manifestation of the typical clinical factors that are measured in the clinic. And that at the end of the day, the particular genomic and clinical factors summate to actually produce a vascular wall phenotype. So progression of vascular injury, as I said, is a continual process. When areas of the blood vessels are damaged, we have deposition of both platelets and leukocytes. And in this electron micrograph, one can see the leukocytes and platelets. And then we can actually have de-endothelialization occurring in the area of that injured blood vessel. And we actually can even see fibrin clots forming. So the typical white thrombus that occurs in vascular injury. Within a matter of days, we begin to see the growth of plaques on that damaged surface. And if we look histologically in cross-section, we actually see that it's composed of smooth muscle cells, macrophages, and collagen production by those smooth muscle cells. And this is typically evoked by the platelet release of platelet-derived growth factor, and then chemotaxis of smooth muscle cells into the lumen, as well as macrophages and other inflammatory cells into the lesion. With the advent of knockout mouse technology, we've been able to follow disease progression in, for example, the ApoE null mouse that develops hypercholesterolemia. And in this study, we actually prepared specimens over a 55-week period. And what we find is that over 2,500, almost 2,500 genes were differentially regulated in the vascular wall. And the largest number of the gene changes occurred from week 35 on to 55. So in basically the intermediate lesion and the fibrous plaque, atherosclerotic plaque development. And when we look at these classes of genes, we find many chemokines, cytokines, and their receptors, as well as a host of lipoproteins, lipoprotein receptors, LDL, VLDL receptors, many genes involved in fatty acid metabolism, as well as the extracellular matrix genes and matrix metalloproteases that are involved in the evolution of the plaques and potentially in the instability or rupture of plaques. So in the brief time that we've been allotted for this presentation, I can't go into detail about all of these different genomic signature effects, but they affect these main categories: producing dyslipidemias, LDL receptor, single nucleotide polymorphisms, gain or loss of function, most commonly the loss of function of hypercholesterol producing hypercholesterolemia, and then gain of function, for example, in PCSK9 that increases the cycling of the LDL receptor, and so that results in high levels of cholesterol. Also, elevated triglycerides can occur, And then hormonal influences. Thyroid disorders can affect the metabolism of the lipoproteins and cholesterol, as well as cortisol. And we know that PTSD, or chronic stress, as we're dealing with right now in the era of COVID-19, can also affect the cholesterol and triglyceride levels. In addition to the dyslipidemias, immunological patterns are extremely important. Hyperinflation, the increased innate immune response that has been discussed previously. This actually increases with age. And so that results in an acceleration of atherogenesis because of the waxing of the innate immune responses and the inflammation that it evokes, at the same time that the B and T cell populations are waning, although T cells are a component of the atherosclerotic plaque, and interferon gamma producing T cells that can be evoked by the innate immune response have been implicated in plaque rupture. Genomic effects also have effects on hypertension via the volume effects, the high renin, for example, in the renin-angiotensin system, and increased vascular reactivity. And then there are a host of cellular adhesion molecules and changes in both the expression of those molecules as well as platelet leukocyte function. In particular, the coagulation system can have gain of function mutations, for example, factor V Leiden, that is predisposes to increased thrombin production, of course, leading to the production of fibrin. And then you can have increased tissue factor. Many of these are actually stimulated by the innate immune response. We actually find that the basal level of coagulation increases as we age. From, if we compare someone who's 50 years old to someone who is 80 years old, in the 80-year-old, there's a 60% increase in the basal coagulation system being stimulated by the innate immune response that can predispose them to very detrimental effects in coagulopathy, for example, in infectious diseases that we'll talk about a bit later. So atherosclerosis increases with age if we go from a 17-year-old to a 71-year-old. And because in the human, this is a disease of decades, we actually see, in addition to those other gene families that I talked about, the addition of calcification. And there's quite a bit of calcification that occurs in these vessels. So the osteocalcine gene is one that's implicated. In addition, even early on, as the plaque of the wall begins to thicken, there's increased vasovasorum, the nutrient vessels that feed the deeper layers of the plaque as it grows. And you can see trafficking of macrophages that, for example, in this case, express legumine, which is a matrix metalloprotease. And as the plaque actually progresses and the lipid-rich necrotic core grows, we see more and more of these cells, macrophages, and endothelial cells producing this matrix metalloprotease that can actually change the character of the plaque, particularly in the shoulder regions of these evolving atherosclerotic plaques. But we don't, we want to be able to image in real time what's going on in our patients. And so now we have the capability to do three-dimensional renderings and assessment non-invasively via CT exams, what's happening in the vessel. And so in this case, if we look at a carotid artery just above the bifurcation and the carotid bulb, we actually are able to actually image the calcified plaque, the degree and amount of the lipid-rich necrotic core that occurs in the artery, as well as the fibrous cap. And if we cut this in cross-section, here again we see the calcified portion, we see the lipid-rich necrotic core, and then we see the lumen that has been constricted by this growing atherosclerotic plaque. In this case, we actually see calcification close to the surface of the plaque. This can actually cause incongruities and wall stress and may actually be a signature of a vulnerable plaque more likely to rupture. So let's go back to inflammation for a couple of minutes just to talk about the fact that many diseases actually result in TNF-alpha excess that leads to IL-6 excess and the hyperinflammation. And the intersection of all those diseases is the acceleration in the atherosclerotic process. In particular, I'm going to speak about one disease, preeclampsia, hypertension in pregnancy, that's characterized by the TNF-alpha excess and insulin resistance, similar to what we actually see in type 2 diabetes. The reason this is important is that the number one cause of death in women is cardiovascular disease, heart attack and stroke. And as we look at women that have developed preeclampsia during any pregnancy, we see that even after we adjust for the other risk factors, that there's a 5-fold increase in the incidence of coronary artery disease in women that are 40 to 64 years of age. And the only one that is more severe is the presence of type 2 diabetes in these women that increases by an order of magnitude the incidence of coronary artery disease. So, but all atherosclerotic plaques are not created equal. This is a rendering of a left coronary artery in an area of constriction. And in this case, there's very little lipid, but in fact, there's an acute carotid artery dissection that's occurred, and intraplaque hemorrhage has compressed the lumen in this particular specimen. In addition, environmental risk factors and lifestyle decisions also can accelerate atherogenesis. Comparing smoking versus vaping, for example, you see that increased systolic pressure and heart rate is more dramatic after a vaping episode as opposed to smoking a cigarette. In addition, air pollution and cardiovascular disease has been linked to cardiovascular disease because of the ultrafine particulates that can actually enter the circulation, excuse me, and actually produce inflammation in the wall. If we look at inflammation, smoking, and aging, we actually see that it can produce the evolution of abdominal aortic aneurysm. And in this case, we see a patient that had acute onset of pain and is actively dissecting that abdominal aorta and producing a rapidly evolving aortic aneurysm that's in danger of rupture. As comparison to a more stable aneurysm that actually has calcification and lipid-rich plaque, but no evidence of the intraplaque hemorrhage. Now to the beautiful setup that all the previous speakers did for me regarding bacterial and viral infections. That innate immune response is set off by the presence of not only the COVID-19, but influenza and bacterial infection, strep pneumonia, so that we have multiple-fold increases in the incidence of heart attack for the first week after the infection ensues versus an increase in stroke that can actually be manifest for up to 28 days after the infection. In addition, herpes zoster or shingles can double the stroke risk and increase the heart MI potential for almost 6 months. And then finally, COVID-19 infection produces that massive prothrombotic activity, not only in the pulmonary, but in the vascular, peripheral vasculature, requiring, in this particular publication, the use of tissue plasminogen activator for fibrinolysis, which actually relieves myocardial ischemia and improves the oxygenation by lysing the thrombi in the pulmonary circulation. However, the physicians in this paper were very worried about giving TPA because of its bleeding side effect. And that's actually what our company, EmstoPA, is developing, is an acute antidote for TPA-induced severe hemorrhage. So now we have the capability to quantitatively assess plaque progression or regression, and can actually assort patients over time to see whether their plaques are progressing or actually regressing. So in conclusion, atherosclerosis is continual response to injury. Multiple factors can influence that rate of progression. And in the post-genomic era, now we can develop a personalized medicine approach to integrate each patient's particular genomics with that vascular wall phenotype and tailor specific therapies for individual patients. And I'll be happy to take any questions now.
What a wonderful talk. Loved it. Okay, so the question what I'm having in the area here where we recognize the complexity of systems pharmacology, is there still space for single talks, or do we have to go into a more combinatorial approach where we look at how do we actually combine treatment modalities really to optimize benefits for the patient? Okay.
I think it's a very good question. I think that, you know, now with the ready access of genomic testing that can easily be done, combined with the, you know, many profiles for multiplexing cytokines, for example, combined with the imaging that's now available for the vasculature, you can tailor.
Yeah. I mean, that is also recommended. Yeah, that's also recommended by the guys on the CRO side. Exactly. So, okay. But what is your thought, Nels, on why? What would that tell us?
I'm sorry.
There's somebody in the line who ultimately is communicating. Okay, so essentially, sorry, I don't know who it is. Somebody is apparently intercepting in our Zoom conversation.
Was it a question, Vivek? It was Mr. Vivek. I don't know if it was a question or just line interrupting.
It's apparently at the procurement side, and the way the conference organizers, those guys are talking and not muting. Okay, so that's essentially what happens, James.
Okay, carry on, James.
I think the bottom line is that now we're able to actually tailor the therapeutics. For example, you know, a patient that actually is experiencing a variety of symptoms with the advent of testing as well as the imaging capability, one could tailor therapy. So, for example, if you know you can assess the response to therapy of by looking at the reduction in that lipid-rich necrotic core, for example, if the patient has is heterozygous for the familial hypercholesterol gene and has the defect in the LDL receptor is statin and the statins and Zetia working. You can actually watch that necrotic core over time to see whether it's increasing or decreasing in size. And if it's not, then you would go ahead, the patient could be treated more appropriately with the addition of Repatha, for example, to negate the PCSK9 gene gain of function mutation that it can occur in those patients as well. So it allows the capability of a true personalized medicine.
And it's a question of I think we both agree. The question what I'm having is when we look at the historical drug discovery mode, where we go for single pathway, single targets, and we know now essentially the interrelationship between all of those different phenomena which essentially play a role in atherosclerosis disease progression. So would one not have in that terms to look now at the problems differently? One addresses essentially cross-pathway communication as the target, okay, because those phenomena are interrelated, which may not be addressable with single target modality or single pathway modalities, which ultimately may exacerbate problems on the periphery, okay, while they may be perfectly fine, okay, looking at a very localized phenomena. So that's really more like a philosophy question. Have we progressed and matured into an area of systems medicine, or are we still essentially with one foot in the old paradigm, which is essentially one drug, one mechanism, one pathway? And do we have to change? And that's more a philosophical question to you.
Yes, I would argue that we want the more systems approach, and we actually look at the multifactorial induction and progression of disease.
Thank you for reaching that agreement. I happen to agree with you too.
Yeah.
Thank you.
Okay, any other questions? Thank you for your attention.